Hello, everyone. Can everyone hear me?
Yes, we can.
Okay. So, we left at endometrial polyp today. Today, we are starting from endometriosis. So, what is endometriosis? So, endometriosis means that the endometrial lining of the uterus has some glands in it. And when those glands are present outside the endometrial lining, anywhere in the body, they are known as endometriosis. It is known as endometriosis. So, if the glands lie outside the lining of the endometrium of the uterus, it is known as endometriosis. Now, what's the pathophysiology of this? So, when the menstrual cycle occurs, the menstruational flow will move retrograde. So, basically, it's the retrograde flow of menstruation, and then it can go to another ectopic site. So, what are the common areas where it can present? So, the first important area I think is the ovaries, rectum, abdomen. Okay. So this is the pathophysiology that retrograde menstruational flow occurs, and these things will get deposited in the pelvis, in the ovaries, in the rectum, and in the abdomen. So now what will happen is that whenever menstrual cycle occurs again, since these glands are present in these areas, these glands will also undergo menstruation. These glands will also undergo shedding. So every month there will be shedding of the glands in these areas, and that gland, and since these glands cannot reach to the outside of the body because ovary has no connection to the outside of the body, rectum has no connection to the outside of the body. So whenever the menstruation or shedding of these glands occur, they will accumulate there and it will cause pain. So there will be pain during menstruation, which will be known as dysmenorrhea, and as well as there will be pelvic pain. And when it affects the ovaries, ovulation won't occur properly, and it won't occur when it does not occur properly, it will lead to the formation of infertility. So the typical presentation of endometriosis will be that a 30 to 35-year-old female comes to you, and that female has cyclic pain in the pelvis, as well as there will be mm, pain with urination if bladder is affected, or pain with defecation if rectum is affected, or abdominal pain if the abdomen is affected, or there is infertility. So this will be known as endometriosis. And one important thing is that it usually affects the uterosacral ligaments. So when the uterosacral ligaments are affected, there will be thickening of these ligaments. So this is the characteristic telltale sign that they will give you in the exam. They will tell you that a woman is having cyclical pains. And when you look in the physical examination, they will say that palpation of the uterus reveals a nodularity or nodular thickening which is present. So this is known as endometriosis. Now, what is the treatment of endometriosis? You give OCPs for the treatment of endometriosis. So that is the mainline treatment of endometriosis. So you have to give OCPs for the treatment of endometriosis. Okay. Now, the one more important thing is that when endometriosis occurs in the ovary, it can lead to increased risk of ovarian cancer. Okay. So now after endometriosis, if the uterine glands, if the endometrial glands are present in the myometrium, this condition will be known as adenomyosis. So what happens in adenomyosis is that the glands will be present in myometrium, which means the muscle layer of the uterus. So when these glands are present in myometrium or the muscular layer of uterus, it will lead to increased bleeding. So the main clinical feature of adenomyosis will be increased bleeding. So now increased bleeding occurs in a lot of other conditions as well. Like we discussed yesterday that endometrial polyps can lead to bleeding. But remember, the bleeding of endometrial polyps would be intermenstrual. That is, it will be present between the menses. But the bleeding of adenomyosis, in which the endometrial glands are present in the myometrium, it will be increased profuse bleeding as well as on physical examination. Okay, and as well as during the physical examination, there will be globular enlargement of uterus. So then uterus will be globularly enlarged and it will be tender. So as far as we have discussed, there are two types. So we have discussed till far endometriosis and adenomyosis. So the physical examination findings of endometriosis will show a thickening of the uterosacral ligaments or a nodular thickening of uterosacral ligaments. Whereas if there is globular enlargement of the uterus, which is tender, and at the same time there will be increased bleeding in the menstruation, that condition will be termed as adenomyosis. And for adenomyosis, we do an MRI. So for adenomyosis, we will do an MRI. And what is the treatment of adenomyosis? Anyone?
Septum
Yes. So the treatment of
Surgery.
adenomyosis is hysterectomy. So
Surgery.
we will remove the uterus. That is the treatment of adenomyosis. Now let us move on to another important topic, that is endometrial hyperplasia. So what is endometrial hyperplasia? So again, if the endometrial glands just enlarge and they are present in the endometrium, but they enlarge, it will cause endometrial hyperplasia. What are the risk factors for endometrial hyperplasia? So remember guys, progesterone will lead to thinning of uterus. That is an important thing that you guys need to remember. Progesterone causes the uterus not to grow, whereas estrogen will always lead to increased growth of the uterus. So whenever there is increased estrogen, and what are the conditions when increased estrogen will be present? So whenever the patient is obese, the patient is on some kind of hormonal replacement therapy, the patient has PCOS, all of these conditions will cause an increase estrogen, and that would lead to endometrial hyperplasia. So the endometrium will become enlarged. And what will happen in this condition is that the patient will have postmenopausal uterine bleeding. So in this condition, postmenopausal uterine bleeding will be present. Now remember one thing. Endometrial hyperplasia is a very important risk factor of endometrial cancer. So whenever endometrial hyperplasia is present, we do some kind of biopsy to rule out endometrial cancer. And another important thing is that if endometrial hyperplasia is present, we do an ultrasound. If the uterine wall thickening, endometrial thickening is greater than 4 millimeter, we need to perform a biopsy. And again, when do we suspect endometrial hyperplasia as a cause of uterine bleeding? If the patient is obese, if the patient has high BMI, if the patient had any form of estrogen replacement therapy, if the patient has PCOS, if the patient had any kind of thing in which progesterone and any anovulatory cycles, because whenever there is an anovulatory cycle, progesterone is not present. So then there will be endometrial hyperplasia that will be present. Okay. So endometrial hyperplasia leads to an increased risk of cancer. So to prevent endometrial hyperplasia, we will give so now to prevent cancer in this condition, we will have to give some kind of treatment. So the best treatment for endometrial hyperplasia is a progesterone IUD. Why do we give a progesterone IUD in this condition? Anyone?
since it's caused by estrogen and progesterone causes thickening and thinning, so I guess it's to reverse the
Yes.
effect.
Yes. So progesterone will
In
lead,
order
progesterone
maybe
always
not
leads to
to,
the thinning
I
of
mean,
the
to be
uterine wall. So that is why we give uh, a progesterone IUD that will lead to the thinning of the uterine wall. So that is an important thing to remember. Now let us move on to endometrial carcinoma. So in endometrial carcinoma, again, the most important risk factor for it is endometrial hyperplasia. There will be postmenopausal bleeding, and there are two ways in which this condition can occur. One is through hyperplasia. So we already know what are the causes of hyperplasia. Whenever there will be increased estrogen exposure, such as obesity, PCOS, hormone replacement therapy. Okay, so one more thing, guys. I already told you during the embryology section, this is a thing that needs to be in your concept. What is the hormone that maintains the pregnancy?
Yes.
Progesterone.
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 Progesterone. Serum
Yes. So
progesterone.
if progesterone is maintaining the pregnancy, the more number of pregnancies that you have, the more amount of progesterone exposure you will have. And the more amount of progesterone exposure that you have, the lesser are the chances of endometrial cancer or ovarian cancer. So remember, whenever there is increased progesterone exposure, the chances of a cancer reduces. And at the same time, if there is breastfeeding, there will be increased progesterone, and that will again lead, because whenever the breastfeeding is present, the woman will not have any menstrual cycle. And when no menstrual cycle is present, less estrogen will be present there. And when less estrogen is present, there will be less chances of cancer. So that is why nulliparity, not feeding the baby will lead to an increased chances of endometrial and ovarian cancer. The other thing is, what is the second way that can lead to endometrial cancer is the sporadic pathway. So in the sporadic pathway, the carcinoma will occur in an endometrium, it is atrophic. So it will be an atrophic endometrioid carcinoma. No. So this is the atrophic type. Okay. And endometrioid is the one with exposure of estrogen. Did you guys get it? And what
Can
is
you
the
repeat?
risk age group in which endometrial carcinoma occurs?
Doctor, can you please repeat about this sporadic atrophic term? The voice is breaking, yeah.
Okay. Okay. So
Yes.
I told you that there are two. Okay. So I have
Yeah.
told you there are two types of endometrial cancer. One is the atrophic type and other is the endometrioid types. So the endometrioid type will occur in those which had long-term exposure to estrogen, such as those with obesity, PCOS, anovulatory cycle, nulliparity, multiple low breastfeeding, late menarche, late menopause. And the atrophic type will occur all of a sudden without any cause. Is it clear?
No, your mic is breaking.
Now
I heard
let
that
us.
type. What is
Can you hear me now? Anyone?
Yes,
yes?
but still breaking. Your voice is still breaking. Yeah.
Wait a second. Oh. Hmm. Can you hear me now clearly?
Yes. Yes.
Okay. So now let us move on to leiomyoma. So what are leiomyomas? Leiomyomas are basically fibroids. So these are the benign tumors which are occurring from the
What's the age
myomere.
group? What's the age
What?
group for the age group for endometrial carcinoma? You wanted to say it before, but you skipped it.
Okay. So I told you there are two types of endometrial carcinoma. Let me just type it for you. Two types. So one is the endometrioid type, okay, and the second one is the atrophic type. So it's the atrophic type. So now remember, the atrophic type occurs in older aged women. So it will most likely occur in those that are above the age of 60s. So it will occur in 60 to 70-year-old. This will occur in 45 to 60-year-olds. This one will occur due to estrogen, and the other one occurs due to P53 mutations. In this, the endometrium will be enlarged, will be bigger. In this one, there will be atrophy and wrinkling of the endometrium. So this was the two types of endometrial carcinoma. Did everyone get it?
Yes.
Yeah.
Okay, so now let us move on to leiomyoma. So leiomyomas are basically benign tumors or the myometrium. So remember, endometrial carcinoma was a malignant tumor of the endometrium, but if a benign tumor of the myometrium is present, it is known as leiomyoma or fibroids. Okay, so what is the most common presentation? And remember, this is the most common gynecological tumor, most common gynecological tumor, not cancer. Okay, so most common gynecological tumor is leiomyoma. Most common gynecological cancer in developed countries is endometrial carcinoma, whereas the most common gynecological tumor in underdeveloping countries is cervical cancer. Okay, so now as we move on to leiomyoma, remember that leiomyoma, what are the clinical features of leiomyoma? Again, there will be increased bleeding that will occur in increased bleeding that will occur in menstrual cycle. But as I've already told you, the increased bleeding also occurred in endometrial cancer. It also occurred in adenomyosis. It can also occur sometimes in endometriosis. So how do you differentiate between these things? So remember, on the physical examination of leiomyoma, there will be an irregular enlargement of the uterus.
Mhm.
Okay.
Yes.
So, as we have studied so far, in the case of adenomyosis, the enlargement of the uterus will be globular and smooth. So, if
Globular
a smooth
symmetric.
globular enlargement of uterus along with tenderness is present, then it will be known as adenomyosis. But if the enlargement of the uterus is irregular, nodular, then it will be leiomyoma. And the histology will show you world pattern of smooth muscle bundles. And at the same time, leiomyomas has some other features as well. There will be some kind of pelvic pressure or pain problem with the urination. Okay, so what is the treatment of leiomyomas? If the leiomyomas are asymptomatic, you do not need to do any treatment. No treatment is needed. But if it is symptomatic, we goes for OCPs as the first line treatment. So that will be the treatment of leiomyomas. Again, it is very estrogen sensitive. So in pregnancies, leiomyomas will enlarge in size, and after pregnancy, in menopause, they will become smaller in size. They have no cancerous potential and they won't lead to cancer. Any question?
No.
Okay. Now let us move on to ovary. The first most important disease of ovary is the PCOS, polycystic ovarian syndrome or the polycystic ovarian disease. So guys, in PCOS, what happens in PCOS is that uh, remember that whenever there is so in PCOS, can does anyone have any knowledge how why does PCOS occurs?
Due to
Ins-
multiple follicles occurs in the ovary.
Hmm?
Insulin resistance.
Yes. So what happens
Of
during
Because the patient presents with infertility, obesity, hirsutism, and amenorrheic spells,
Okay.
amenorrheic cycle. Yeah.
So they love this pathophysiology or pathophys of
Anovulating
PCOS.
cycles, anovulation.
Yes. So whenever there's obesity, that leads to insulin resistance. So whenever due to obesity, insulin resistance occurs, it alters the hypothalamus. And when the hypothalamic response is altered, LH rises as compared to FSH. So they ask you this question in an exam a lot, that if a patient is diagnosed with polycystic ovarian syndrome, or if the patient has oligomenorrhea, amenorrhea, infertility, hair, eh, hair on her chin, and she's obese, what will be the characteristic biochemical abnormalities that will be present in this patient? So remember, the biochemical abnormalities that will be present in this patient will be increased LH to FSH ratio, which will be more than 3 to 1. And at the same time, testosterone will be increased in this patient. So what happens when testosterone increases? When testosterone increases, the ovarian follicles don't mature. And when the ovarian follicles do not mature, it leads to the follicles not being ruptured, and there will be no ovulation. So that is why how an ovulation occurs. And when an ovulation occurs, no progesterone is secreted. So when no progesterone is secreted, and it will lead to thickening of the endometrium. And when the endometrium will be thickened, it can increase the risk of endometrial hyperplasia and endometrial carcinoma. And at the same time, since no ovulation is occurring, fertility will be reduced in females. So, what is the criteria? We know we call it as the Amsterdam criteria for PCOS. So, the Amsterdam criteria say that there should be ultrasound changes, which shows cysts in the ovaries. At the same time, there should be ovulation changes. So there should be oligo and ovulation, and at the same time, there should be the presence of hyperandrogenism. So if two of these things are present, then we confirm the diagnosis of polycystic ovarian syndrome. Now, what are the associations of polycystic ovarian syndrome? They love to test these associations. The first one is obesity. So whenever the patient is obese, it is present. Second thing, endometrial carcinoma.
Mm.
The third one is diabetes. So they can give you a patient with polycystic ovarian syndrome, and they can ask you, what else do you want to check in this patient? So you will check for the presence of diabetes in this patient. And at the same time, the patient will have some kind of acanthosis nigricans. What is the treatment for this condition? As far as treatment is concerned, we go with OCPs, weight loss. So what will OCP do? OCPs will cause the endometrium to thin. So when the endometrium is thin, there will be less chances of endometrial hyperplasia, endometrial carcinoma. For weight loss is, so we get rid of the root problem and the cycles are regulated. And the third thing is, for ovulation, we'll give this patient clomiphene. Does anyone have heard about the drug letrozole? So remember,
Given
for
for
PCOS,
ovulation induction.
yes. So remember, we first gave letrozole for ovulation induction in the patients of PCOS, but we discovered that letrozole led to the development of multiple babies in a female. So there were three, four, or five pregnancies in a female at the same time. There were quadruplets, there were triplets that were present due to the letrozole, and the babies did not survive, and they were born dead, or they were born still. So they were stillborn or dead babies. So we started using clomiphene now. So if the question mentions both letrozole and clomiphene, you have to go with clomiphene. We do not give letrozole anymore for the treatment of this condition. And for the treatment of hirsutism or hair which are present on the chin, we will give spironolactone. So the spironolactone is the first line. And what is the mechanism of action of spironolactone?
Androgen receptor
Androgen
antagonist.
antagonist.
Yes, so it is
Antagonist.
androgen antagonist. Okay, now let us move on to ovarian tumors. So again, what are the risk factors for ovarian tumors? The most common, what is the most common risk factor for ovarian tumor? Anyone?
Nulliparity.
Y- Yes, the most common one is advanced age. And then nulliparity, again, anything just increases the estrogen exposure. So early menarche, late menopause, endometriosis, BRCA1, BRCA2 mutations, and what are the things that reduce the risk of ovarian cancer? So that would be breastfeeding, OCPs, or tubal ligations. Now again, there are two types of endometrial tumors, ovarian tumors. There are three types. So they can be epithelial type, they can be germ cell types, they can be sex cord stromal tumor types. So these are the main types of the tumors. What are the clinical features? How do the and ovarian tumor occurs? There will be a characteristic presentation that a 55 or 60-year old female came to you, and now that patient has abdominal distension or bowel obstruction or pleural effusion or peritoneal effusion or ascites that is present with the patient. So if any female with 60 years or 50 years of age presents to you with constipation, bowel obstruction, or enlarged or protuberant abdomen, the first thing you have to rule out is ovarian tumor with an ultrasound, because most likely that patient will have some kind of ovarian tumor that is leading to ascites or abdominal obstruction. Okay. Another thing is that how do you monitor the ovarian tumors? So for the monitoring of ovarian tumors, we can measure CA125 levels. But again, this is something that we do not use for the screening. Never use it for the screening of ovarian tumors. Did you get it? So now
Yes, it's
there are
for the
so now
treatment.
yes, it's for the treatment response, not for other things. So, first of all, there are three types of ovarian tumors: epithelial tumors. The second one are germ cell tumors, and third ones are sex stromal tumors. So, epithelial tumors can be lined with serous epithelium or fallopian tubes, or they can be lined by the mucinous epithelium of the cervix. And for these tumors, we'll use CA125. So now again, there are five types: serous cystadenoma, mucinous cystadenoma, Brenner tumors, serous carcinoma, and mucinous carcinoma. You can read about these. These are not as high yield. But now we'll move on to the germ cell tumors. So for the germ cell tumors, the important thing that you need to remember are the tumor markers. So what tumor markers are present in different type of germ cell tumors? Because if they give you some kind of ovarian tumor, they are expecting you to know every type of the tumor marker that is present. So they can, first of all, they can be your yolk sac tumor. So in yolk sac tumors, AFA will be elevated. In this germinoma, in this germinoma, HCG and LDH are elevated. And so now these are the two, they are the most likely test. The third one is mature cystic teratoma. So it is known as a dermoid cyst. So the most important thing about a dermoid cyst is that it is a kind of a tumor. This is the most common ovarian tumor. This tumor is the most common ovarian tumor that is present. And the important thing about this tumor is that it has all three layer of germ layers. So remember we talked about the the mesoderm, the endoderm, and the ectoderm. So all these three layers will be present in this tumor. So there will be different types of things that will be present. So they can give you a question that a female had an ovarian mass, and when you check that ovarian mass revealed a lot of hair, teeth, bone, sebum, things like that. So that will be a dermoid cyst or mature cystic teratoma. What is the most common complication of this thing? That would be ovarian torsion. So remember, if a patient has mature cystic teratoma or dermoid cyst, that patient has a lot of chances that that patient will have mature cystic, that the patient can have ovarian torsion. So if a patient of ovarian torsion comes to you, if a 25-year-old females come to you and that patient has nausea, vomiting, abdominal pain, all of a sudden, and you do ultrasound and you preserve and you see that there are some cells, there are some kind of hair cells or teeth that are present in the ovary, and they ask you what is the cause of this condition. So the cause of this condition will be a dermoid cyst or a mature cystic teratoma. One more thing is that these cells, these tumors can have thyroid cells within them. So whenever they have thyroid cells within them, that can lead to the formation of hyperthyroidism. So this condition can present with hyperthyroidism as well.
So that is called Kokenberg.
No, Krockenberg tumor is something else. This is not the Krockenberg tumor.
They test trauma overall, not the
Yes, so that would
Kruger.
be stroma aurora. So, what is Krockenberg tumor? So, Krockenberg tumor means that if a gastric carcinoma, gastric adenocarcinoma is present in the ovary, that would be termed as a Krockenberg tumor. This thing is known as stroma overa, okay, right? So, after that, there is immature teratoma that is not as much as important. Then there is dysgerminoma. Dysgerminoma is the male equivalent of seminoma. So this is the male equivalent of a seminoma. And the histology will show you fried egg cells. A lot of things in the ovarian tumors are to be crammed, but the important points, the important conceptual points that you need to remember, I will tell you about those. So it will lead to increased formation of HCG and LDH, and it will be equivalent to a male seminoma, and there will be HCG and LDH. Now, let's go on to the sex cord stromal tumors. So in sex cord stromal tumors, the first thing that you need to remember is where do these arise from? So these tumors arise from the sex cells. And the main sex cells that we have in the body are the granulosa cells or the Sertoli cells. Sertoli lytic tumor or the granulosa cell tumor. So as the name tell you, the Sertoli and lytic cells, can anyone tell me what structures do, what things do the Sertoli and lytic cells produce?
Testosterone.
Yes, so these
Ladies
produce
that
testosterone.
testosterone.
So these, whenever a tumor, so if they give you a female with an age of 25 to 30 years, and that female has rapid hirsutism, rapid male-like things which are present. So if her clitoris is enlarging rapidly, or if there is male pattern baldness all of a sudden, or there is hirsutism all of a sudden, then that, and the patient has an ovarian mass as well, and they ask what kind of a tumor does this patient has. So that tumor will be a Sertoli lytic cell tumor that will be present. Again, these kind of things are present in PCOS as well. So people, so a lot of students are confused. How do we differentiate between Sertoli lytic cell tumors and PCOS? So remember, in PCOS, the clinical features that occur. So in PCOS, the features that occur will most likely be related to hirsutism. So there will be just increased hair that will be present on the female body, but at the same time, no clitoral enlargement will be present, no voice deepening will be present. If clitoral enlargement, voice deepening are present, then it means there is some kind of ovarian tumor which is producing testosterone. And you already know that which ovarian tumor, that Sertoli cell tumor is the one that produces a lot of testosterone. And the other one is the granulosa cell tumor. So granulosa cells are present in females and they give rise to estrogen. Okay. So increased estrogen will be present in these females. And I have
Mhm.
already told you, when increased estrogen is present in the females, what can you expect in those conditions?
Endometrial
Abdominal
hyperplasia
Yes, so
and
hyperplasia.
they will
heavy
have
bleeding.
endometrial hyperplasia, they will have endometrial bleeding, and ultimately they will have endometrial cancer.
Cancer. Yeah.
So whenever a patient of granulosa cell tumors come, which the histology of which will show you call external bodies. So they will be call external bodies in the histology of that. And inhibin will be produced because inhibin is produced by the granulosa cells. So whenever that is present, you need to do a biopsy of endometrium as well to rule out endometrial cancer. Okay. And if this tumor occurs in an age of 8 to 9 years old female, so if they give you a female of 8 to 9 years old and they tell you that this female is having breast tenderness or her breast buds are present fully, or the patient is having secondary sexual characteristics at the age of 8 years, then you and there is some kind of ovarian mass that is present, and they ask you what kind of ovarian tumor is present in this patient. So the most likely answer would be a granulosa cell tumor, and they could ask you about the histology. So the histology of that tumor would be called external bodies. And if they ask you about the marker of the tumor will be inhumbin. Another tumor that is a sex cord tumor is the fibroma. So fibroma is very simple. It is due to the proliferation of spindle cells fibroblasts. The important thing about this tumor is that in this tumor, Meek syndrome occurs. So, what is Meek syndrome? There will be ascites,
Site is an ovarian cancer.
ascites, pleural effusion, and an ovarian mass. So remember, guys, if all three of the things occur at the same time, the ascites, pleural effusion, and ovarian mass, that means that the patient is having an ovarian fibroma. So an ovarian fibroma is present in that kind of a female. Is everything clear till now?
Yes.
Yes.
Yes. So now we will move on to gestational
Yes, but I
pathology.
have a question. What do you
Yes.
say is the ratio of LHFS in PCOS?
Yes. So the ratio of LH to FSH will in PCOS will be 3:1.
3:1.
3:1.
Okay, thank you.
So now let us move on to gestational pathologies. So the ovary is completed, and now we move on to gestational pathologies. The first one is ectopic pregnancy. So what happens? What is ectopic pregnancy? So in ectopic pregnancy, an ovum, a fertilized ovum, is implanted at a place other than the uterus. So the ovum will be implanted in fallopian tube or some other place. The most common place is the isthmus of the fallopian tube. And what is the most common cause of ectopic pregnancy? It is a
Um,
history of pelvic
PID,
inflammatory.
PID
Yes.
are the
previous
PID.
pelvic surgery.
surgeries and scarring, scarring
Yes.
and
So
adherence of the.
PID, which leads to scarring and adherence. And again, in developed countries, chlamydia and gonorrhea are the most common cause of PID, whereas in underdeveloped countries, TB is the most common cause of ectopic pregnant of pelvic inflammatory disease. Another thing is that what would be the presentation of this condition?
Patient presents with the vaginal bleeding and lower abdominal pain, cervical motion tenderness, and usually at the 7 weeks of pregnancy.
Yes, so
Pregnancy
abdominal pain,
correspondence.
cervical motion tenderness, and bleeding will be present in the female, and there will be history of missed menstrual cycle in this female. So the
Yes.
first thing that you do whenever a patient of reproductive age of 20 to 35 years old comes to you with with abdominal pain, the first thing that you need to do in that patient is to order an HCG. If that HCG is
Present
positive,
with this.
then that means that patient is having some kind of ectopic pregnancy. But if that HCG is not positive, then the patient might be having an appendicitis. So remember, whenever ectopic pregnancy comes, always keep a diagnosis of appendicitis or ovarian torsion at the back of your mind. So what is the treatment? If the HCG is less than 5,000, you give patient methotrexate. What is methotrexate? It is a folic acid synthesis inhibitor. So so not folic, but the nucleotide synthesis inhibitor. And if it is more than 5,000, then we do a salpingectomy in these females. What is placenta previa?
And
So if a
placenta is
we,
at the, yeah.
yes,
When placenta is at the lower segment of the uterus.
yes. So if this
Yes.
is so if it is the uterus and placenta is covering this part of the uterus, then it is known as a placenta previa. It covers the cervix, and what when this happens, there will be bleeding at this part. So remember okay. So now remember in okay. So in placenta previa, the bleeding will be painless. So if in third trimester, painless bleeding is present in a female, and they ask you about the diagnosis of this condition, then the diagnosis would be a placenta previa because the placenta is lying at the lower cervical os. And what is placental abruption? So another cause of bleeding. So these are the causes of third trimester bleeding. So there are four causes of a third trimester bleeding. So if a female is in her third trimester and there is bleeding, then there can be four causes of third trimester bleeding. The number one is placenta previa, in which there will be painless third trimester bleed. Then there is placental abruption, in which the bleeding will be painful and it occurs due to the separation of placenta from the uterus. So if the uterus separates from the placenta, then there will be third trimester bleeding, which will be painful. Then there is uterine rupture, in which the uterus ruptures and there will be again painful bleeding. So how do you differentiate between placental abruption and uterine rupture at the same time? So remember, in placental abruption, you can still feel the uterus. So when in placental abruption, when you palpate the abdomen or you do a physical examination finding of the abdomen will be tense and the uterus will be very tense because the placenta has been separated. So the uterus is trying to contract as much as possible to separate to make sure that the placenta stays attached to the uterus. But in uterine rupture, the abdomen will be smooth and no and the uterine contour will be lost. And the fourth cause is the vasa previa. So what happens in vasa previa is that the fetal vessels come at the cervical os, and the fetal vessels will lead to painless bleed. So how do we differentiate between placenta previa and vasa previa? So in vasa previa, since the bleeding is from the fetal blood vessels, the bleeding will be very low. It will be minute bleed or a little amount of bleeding will occur. But if there is profuse painless bleeding, then that would be due to placenta previa. I told about four causes of third trimester bleeding. Two are painful and two are painless. So the painful ones are placental abruption and uterine rupture, and the painless ones are placenta previa and vasa previa. So again, how do we differentiate between the previa and the vasa previa? So if the painless bleeding is heavy in amount, then it will be a placenta previa. But if the bleeding is minuscule in amount or very less in amount, then the condition would be known as a vasa previa. Again, to differentiate a placental abruption from uterine rupture, if the bleeding, if the bleeding is painful and at the same time you could feel the uterine contour through physical examination, then it is a placental abrasion. But since in uterine rupture, the uterine contour is lost, then it would be painful bleeding without the presence of a uterine contour that would be present. Placenta. Now we'll move on to another cause of bleeding, which is placenta accreta, which occurs after the birth of the baby. So what happens? So what happens in placenta accreta is that placenta attaches too further into the uterus and it does not separate after the delivery. So when we try to separate the placenta after the delivery, it leads to a lot of bleeding, and then we have to do a hysterectomy. So if the NBMEs or the USMLEs give you a question that there was a delivery of a baby to a female, and after the delivery of the baby, a lot of bleeding was occurring in the female, and we tried to stop the bleeding, but the bleeding did not stop. Then they will tell you in the question that the placenta still hasn't been delivered, because within 30 minutes of pregnancy the placenta has to be delivered. So if they will say you that after 1 hour of pregnancy, the delivery, the placenta still hasn't been delivered, what is the most likely diagnosis? And so the most likely diagnosis would be a placenta accreta. Now, the third thing is preeclampsia. So, we have already covered preeclampsia in the embryology section. So, it is a pregnancy induced hypertension in which proteinuria and edema also occurs. What are the most common risk factors? Again, hypertension, diabetes, chronic kidney disease, chronic liver disease are the most common risk factors. And why does this happen? The pathophysiology was linked to endothelial dysfunction that led to the formation of vasoconstrictors, and since vasoconstrictors were present, so that led to preeclampsia. If with preeclampsia, so what are the hypertension threshold for preeclampsia? So it is 140/90. So if the blood pressure is greater than 140/90, that means that the patient is having preeclampsia along with some kind of a proteinuria. The proteinuria must be present in the urine. So if preeclampsia occurs along with seizures, then it is known as an eclampsia. And there is another condition which is termed as HELP syndrome. So what happens in HELP syndrome is that the liver blood vessels of the liver are blocked due to thrombi formation. So thrombus leads to the blockage of the blood vessels in the liver, and then there is hemolysis. So there is HELP syndrome. So there is hemolysis, and since the liver enzymes, so since the liver is damaged, the liver enzymes are elevated. So elevated liver enzymes are present, and low platelets are present, because whenever there is a microangiopathy, is I think you have studied this in hematology, uh, about Sh- Shiga toxin syndrome,
Yeah.
hemolytic uremic syndrome. So this is very similar to hemolytic uremic syndrome. In hemolytic uremic syndrome, microangiopathy occurs in the kidney. So in this condition, microangiopathy occurs in the kidney as well as the liver. So whenever microangiopathy occurs in the kidney, the blood vessels are cleaved off. So the red blood cells are cleaved off, and that leads to hemolysis, anemia, and platelets are low as well. And since it occurs in the liver as well, the liver enzymes are elevated. Whenever eclampsia and HELP syndrome occurs, we need to do immediate delivery of the baby. But in the case of preeclampsia, we can give antihypertensive drugs, and we have already touched upon that which antihypertensive drugs we need to give to this in this condition. Now we are moving to on to the last topic of the female reproductive pathology, and that is hereditary form norm. Okay, so let's move into the hereditary form norm. Okay, so what is a hereditary form mole? So it happens when there is improper fertilization process. So whenever, so no, first of all, there are two types of hereditary form mole. One is a partial mole and the other one is a complete mole. So in partial mole, what happens is that a ovum fertilizes with two sperms. So an ovum has 23 chromosomes and two sperms will have 23 plus 23. To total 69 chromosomes will be present. Whereas in a complete mole, an empty ovum, so it means zero sperm, zero chromosomes here, will be fertilized by two sperms. 23 plus 23. So total 36 chromosomes will be present. But all of these chromosomes will come from the father. Nothing will come from the mother. Okay. Okay. So now since
I want to ask you a question. You mean in the partial and the complete? They will, in the both cases, they're gonna come from the father?
I don't know. Yes. So the sperm will come from the father, but the ovum will come from the mother. But in case of a partial mole, the ovum that comes from the mother will be complete. Whereas in the case of a complete mole, the ovum that comes from the mother is not is empty. There will be nothing that will be present in this complete mole. Okay.
Yeah, okay. Got it.
Okay. So since ovum is present in the case of partial mole, some kind of a fetal tissue will be present. But since no, remember guys, the ovum contains all of the nutrient supply of a baby in the early stages, right? So the nutrient supply of a baby comes of an embryo will come from the mother. It won't come from the father. Because sperm is very small, it has to travel a lot of distance. It cannot be heavy. It cannot carry a lot of nutrient supply. Whereas ovum will stay in its place and it will be very heavy and it can carry all of the nutritional supply. So if a normal ovum is present, fetal tissue will be present. But if no normal ovum is present, no fetal tissue will be present. And now let us move on to edema, villus edema. In case some kind of edema will be present,
I'm
and in the
sorry,
other
Doctor.
case, yes,
Sorry to interrupt. Dr. Mas, can you please just shed a few seconds on the XXXY part of partial and complete? I couldn't understand that.
okay, wait a second.
Thank you.
Okay, so remember, complete mole has, so see, so let's first move on to partial mole. So in case of a partial mole, one ovum is present and one ovum will have 23 chromosomes, and since it is coming from a mother, it will be an XX. Okay.
Yes.
Plus two sperms will be present. Now these sperms can be 23XX and this can be 23XX. In this case, it would become 69XXX. This will give you only X, X, and X. Now, if the combination is like this, 23Y, 23X, then it will be 69XXY. Or if it's like this, 23x 23y, because remember the father can give you an x or y, the sperm can contain an x or a y. So if the sperm contains an x, then the resulting baby will be a female, and if the sperm contains a y, the resulting baby will be a male. So in this condition it will be x69 xyy. So did you get this part of the partial mole correctly?
Yes, thank you so much. It's clear
Okay,
now.
now let us move on to a complete one. So in case of a complete mole, ovum which is present is zero. It won't give anything. Then we will have a sperm. Two sperms. So this one sperm can be 23x, the other sperm could be 23y, so it will be 46xy. Or one sperm could be 23x and the other sperm could be 23x as well. Then it will be 46xx. Is that clear?
Yes, yes. Thank you so much.
Okay.
Thank you.
So in case of a partial mole, since ovum was normal, so there will be some kind of fetal parts will be present. So fetal parts are present here. Fetal parts won't be present in complete mole because no ovum was present. Again, since some kind of ovum was present in the partial mole, there will be less edema. But since no normal baby is being formed in a complete mole, a lot of edema will be present here. Okay. Now let's move on to P57 protein, which is a marker. So P57 is a protein which is present in the ovum. So in case of a partial mole, P57 is present. Whereas in the case of complete mole, no P57 protein is present because it comes from the ovum and no ovum is present here. Okay. Now let us move on to the HCG. The HCG will be more raised in a complete mole. It won't be raised as much as the sin. So remember, one more thing is that HCG has the when there is a lot of HCG that is present, HCG shares the same beta subunit as that of thyroid stimulating hormone. Did you guys get this thing?
Yes.
Okay, so since the beta subunit of both of these things are same, HCG can perform the same symptoms as that of thyroid stimulating hormone. So in remember, whenever a mole is present, HCG increases to more than 1 lakh. So normal HCG is almost 10,000 or 20,000. So if the HCG goes on to become 1 lakh, it will act as thyroid stimulating hormone. Thyroid hormone synthesis will increase a lot and it will lead to thyroid storm. Okay. And at the same time, preeclampsia will be present early in these people. So if they give you a condition that a mother comes to you with more than 1 lakh HCG and she is having tremors, sweating, hyperthyroidism features, hyperemesis gravidarum, which means early vomiting in the pregnancy and preeclampsia before at the age of 20 weeks of gestation, then it means that then the female is having some kind of mole. And again, they can give you and then they can show you the ultrasound shows fetal parts. So if the ultrasound shows you fetal part, it means it is a partial mole. But if the ultrasound shows you honeycombed appearance or snowstorm appearance or cluster of grapes appearance, then it will be a complete mole. And then they can ask you, what is the risk of conversion of this thing into a cancer? So invasive mole is a form of cancer. So so they ask you what is the chance of cancer in this condition. So if it will be a complete mole, there will be increased chance of a cancer. Whereas in the case of a partial mole, the chances of cancer are very less. They can ask you about the treatment. The treatment is very simple. First of all, you have to give dilatation and curettage, DNC. And then they can ask you what are the complications of this dilatation and curettage. So the complications will be very simple. It can lead to Asherman syndrome. Okay. And then we have to give methotrexate. But remember, after giving these things, we need to perform periodic surveillance through HCG. Why do we need to perform this HCG surveillance? We need this HCG surveillance to make sure that we need to make sure that all of the mole has been completely removed or it has not given rise to choriocarcinoma or invasive moles. Right? So that marks the end of our female reproductive pathology. And now the male part is left. Does anyone have any questions till now?
Yeah, I just want to ask you one question. What you just said about the ultrasonography, that what we're gonna see for the complete and for the partial, honeycomb for partial, and what more you said?
No. For partial moles, since I told you the partial mole has some kind of fetal parts, so it will show you fetal parts. whereas a complete mole will show you honeycomb appearance or snowstorm appearance or cluster of grapes appearance. Okay,
Okay, thank you.
welcome. Any other question?
I could you go over the partial and the complete mole once again?
Okay, so let me go once again through it. Okay, so remember, guys, in the case of a partial mole, what happens is that one ovum fertilizes with two eggs. So there are 69 chromosomes that are present, and there will be fetal parts that will be present, but the development won't be complete, and there will be a lot of there will be some kind of edema that would be present. HCG won't be as much elevated in this condition, and there are less chances of being converted to a cancer in this condition. P57 protein will be positive since it comes from an ovum. Now, how do these moles present? So they will give you a condition that there is amenorrhea, there is bleeding, there is hyperemesis gravidarum, there are signs of hyperthyroidism, there are signs of preeclampsia before 20 weeks of gestation, and the HCG is in lax. At the same time, they will ask you to differentiate between complete and a partial mole. So, in the case of a complete mole, one empty ovum would combine with two sperms, and then that combination could be 46XY or 46XX. In this condition, no fetal tissues will be present and a lot of edema would be present, and the HCG would be elevated to lax, and then that would lead to hyperemesis gravidarum and all of those conditions in that case, and no P57 will be positive and there will be increased chances of cancer. So that is the main things between these two.
Excuse me, doctor.
What
Yes.
did you say about the edema part?
Actually,
Doc.
yes, can I ask the question?
Yes.
Sir, actually, the thing that confuses me is that in the first study it written like that in the partial mole, basically there is one egg and two sperms. But for the complete mole, there is no ovum, but not two sperms. We are saying it is a single sperm that like duplicates later on.
Okay, so in the case of a complete mole, two things can happen. One thing is that two single sperm will duplicate and it will form two sperms, or two separate sperms can come and then they can form a single sperm. But
Okay.
again, the thing will be same. At the end, there will be two sperms. So two sperms can come from two things. One way is that a single sperm will duplicate itself to form two sperms. So in and the other thing is that two separate sperms are coming and they are forming and they are combining together.
Okay. So basically both are possible. Okay.
Yes, though both are possible. So if the one thing is possible, most likely scenario will be 46x6, because a 23x will come, it will duplicate and it will form 23, and it will combine with a 23x again, which will be a duplicated form, and 46x6 will be formed. And 46xy would most likely be possible when 123x and 123y comes.
Okay.
Yes.
Thank
Doc, what did you say about the edema part between partial and complete mode?
So the edema will be more prevalent in the complete mole because no fetal parts are present. So only edema would be present there. There will be cysts, and the cyst will, because no ovum is present, the sperm won't lead to any formation of any fetal parts, and the development will only consist of cysts. So only cysts and fluid and edema will be present. That is why in ultrasound we are also seeing honeycombed appearance or snowstorm appearance or cluster of grapes appearance, which means that there will be empty spaces and those spaces will be filled with fluid.
Yes. Okay. Got it.
Okay.
Thank you, sir.
Dr. Subera Khan asked a question: why does management changes with HCG levels? I think she was asking about the ectopic pregnancy. So, once the HCG levels are more than 5,000, the ectopic pregnancy has grown so much that the methotrexate is not enough to completely remove it. So, it is implanted a lot in the fallopian tubes. And the only point thing is that point that we can do is we have to remove the tubes at that point. So there is no point of giving the methotrexate because it has embedded so deep in the fallopian tubes. And the only thing that we can do is we can do a salpingectomy. It's very similar to a pregnancy abrupt abortion, in the way that in early pregnancy weeks we can give a methotrexate or mifepristone for the abortion of a pregnancy. But once the pregnancy develops further, no medical management would be enough, and we have to do some kind of dilatation and curettage to remove the fetus and to perform a complete abortion. Hope that
Thank
answers
you.
the question.
Thank you. Yes, thank you so much. The logic was excellent. Thank you.
Welcome. Okay. Okay, so now we'll continue tomorrow. For now, take care, everyone. It was lovely speaking with you. Bye.
Thank you so much, Dr. Maz.
Thank you so much, doctor.
Thank you.